All right, everyone. So I hope everyone is doing well. So my name is Dr. Shahriar. We're going to start the session. And today's session is on the May 2022 recalls. Let's see, how it goes so far. And in the beginning of the session, we'd like to start with how you all are doing. And secondly, from, which city you are attending the session, please let me know in the chat option actually. All right. So, if you have, let's just communicate and build up the community, and then let's just start. So let's start it with, from which city you're attending the session. So just let us know in the comment section, all right. That is fantastic actually. So probably we're connecting almost, over 30, 40 countries at a time. So that is really good to know actually. Yeah. Many of you might be, a little scared before your exam, which is not uncommon, to be honest. Yeah, so just give me a second. Great. So here's the file, which we're going to cover today, and I hope so it will be useful for you guys. And also, I'd like to ask you, when is your exam, so that I can give you guys a little idea, how to strategize in next 3-4 minutes, and then get into this slide. All right. So please let me know in the comment section in which month is your exam is actually, right? Great. So I can see from the chat, a lot of people are in September, November. Yeah. So yeah, few maybe in June. You can see, okay, very close. This month, yes. All the best. All I can say is all the best. Actually, there's a funny thing. Someone asked me, Doctor, what is the suggestion? It's like next day's exam. So I answered, no suggestion is the best suggestion the day before the exam, actually. So yeah, so that's okay actually, and nothing much you can do. And one thing I want to tell you guys that uh, this can be a good way if you can go to your exam center. Right, a good sleep is important because you can ruin your next day morning. So that is something, because your exam can be also in very early morning. Some people's exam is in 8 a.m. morning. So in that case, you really have to get up very early. To be honest, it's very difficult to sleep actually if you're sleeping the previous 7 days, like 2 or 3, or maybe even is like 1 or 2. The next day, getting up at 6 is difficult. Now, if you're, no matter your exam is in morning shift or evening shift, I highly recommend to see the exam hall the day before the exam. Or if you're already living in, say, Australia, I know you can just directly, put that, address, and any other day you can go and see that center. You should you should know where is the center, because in Australia, let me tell you, if you're thinking GPS is too good, but sometimes, these exam centers are in, in 13th floor, 14th floor of different buildings. All right, so the easy it looks like, it's sometimes not actually. So you should exactly reach, to the room actually which exam is conducted. Of course, you can't enter, but at least you should go and see those things in before the exam. So this is a tip I always give to many of the doctors actually. So that take away some of the stress actually. Like last day, you can't really do anything other than, it will be a warm up. Like, you can go to that center and little fresh air, because in last 7 days you were really studying like crazy. So maybe in the last day, maybe in the after early morning, a little bit study, and you close up the things by 1 or 2 p.m., and then go and see that center actually. That makes sense actually. Also, especially if you are traveling to a different country, it is even more important, because you even don't know how to reach there actually. Is it by Uber or by a taxi? If you're going to India, there's like other taxis like Ola and many other things. So you need to find it out. Okay, so that's like little tip. So before the day before the exam, make sure in the last moment you revise, especially in last 7 days. At least the last 3-4 months compiled recall. or maybe 6 months. If you can revise it, actually, that will be really, really helpful. Of course, your theory will lift you up in the main exam. If you don't think that because of the recall you pass in the exam, of course, the theory you are also learning and the concept you are gaining, that will also definitely gonna help you in the exam. If I go back, like, in 2015, 16, 17, 18 even, during that part, a lot of people used to be directly repeated from the same portion. Now, uh, it's nowadays it's a little difficult actually to get direct recalls actually, and there'll be a lot of twist and turn, and also the shuffle questions a lot actually. Say now, I was watching a question today. I'll show you one of the question. It was a 2016 question. It was in that AMC bestseller. I have a book named AMC bestseller. So that one has questions like 2016, 17, 18, 15. That part of questions, and but after that I didn't update that book much actually, to be honest actually. So when I see that question, I understood, okay, that's from directly from that book actually. One of the recall today, I'll show that one is exactly same. So that means because I've been following a lot time, and probably I remember things well. So exactly that was a 2016 question actually, to be honest. So that's the thing, like, different time they will reshuffle questions and bring the old ones, because they also know that you mostly target the very new ones actually, right? So let's get back, and that's why we help candidates by making different forums. um, let's just see how it goes actually. Yes, so without any further delay, let's go and start the session, and this is the session made to the AMC MCQ. I hope you guys are excited to do that. Let's go and start the session actually. Okay, so this is the very first question for today, which is popping up in your screen. A child is having a psychotic problem. See, in the main exam, they will not tell you psychotic problem. They will tell you exactly what is the problem. But psychotic problem, maybe his behavior is not right, or maybe a little bit agitated and started risperidone. Yeah. So what should be the suspected in the consequence? Now you have like this four options, like, and you have to pick up one. All right, it's a very new question, guys. So what do you think about the answer? You can add the answers in the comment section, and let's just go actually. Okay, so a lot of doctors are answering this thing as a gynecomastia in the sequence. All right, no worries. Keep it up, guys. Well done. Well, sometimes, I hope sometimes I like drawing pictures. A very interesting picture I'm going to draw for some people. Yes. Now, you guys are correct, actually. I own mine. Yeah. Now, thing is, this is we call it bamboo. In our country, a very familiar word is bamboo. Actually, we call bash sometimes. Uh, Thing is, that's just a, like, word, like, what should be suspected in a sequence. Now, question. In a sequence means, the starting early, going through the late, do you think, giving risperidone gynecomastia will be the first thing to start it with, or the gynecomastia is the last thing to happen in such cases? And next thing is coming, is that a common complication as well? I mean, the gynecomastia. So we learn that, yes, risperidone is a possibility of causing gynecomastia along with many other drugs, but is that one of those things actually? Now, which one is more common in the sequence? Let's just see in that way. Now, we picked up weight gain, which I'm going to explain why in this case, actually. This was collected initially, it was like up to C. Then one of the doctor confirmed that weight gain was also there in that option, actually. So uh, let's just see some of the side effects. Let me turn off myself so that you can see the screen well. Now, these are very common thing with a drug like risperidone. Risperidone is a antipsychotic drug, of course, and it's very commonly, it is related to, yeah, of course, it can raise the prolactin level. Now, do you think raising prolactin level means gynecomastia, guys? please clarify this thing. Raising productive level means gynecomastia. This statement is right or wrong? So what they will do, they will immediately maybe raise the productive level, and that will lead to what? Gynecomastia or galactoria, guys? Gynecomastia or galactoria? What do you think, guys? So if something come immediately, that is, you can say high prolactin. Remember, prolactin and dopamine. There is a, if you have a scale like this, two different scale like this for weighting. One is prolactin, one is the dopamine, right? So when you give something, one goes up, one goes down. It's like that. So because of the dopamine effect, eventually, there is leading to galactoria. That's one of the. So prolactin, so increased prolactin level, so which leads to galactoria actually. So gynecomastia is not in the same, So if you talk about the sequence, like, so immediately because of the effect, some of the receptor like dopamine receptor. So some of the immediate effects can be high prolactin, okay, and it leads to galactoria. Now, agitation can be also one of those side effects that can happen. That is a possibility. Apart from that one, they can also lead to some of the other problems like insomnia and also uh, weight gain. Now, if we go back again, now what do you think? Which one do you think you want to put it in as an option? First of all, the receptor blocking things like risperidone can block the dopamine receptor, histamine receptor, some of the other receptors, okay, and can lead to some of the side effect. But at the same time, it's also related to those weight gain related thing. Okay, so the thing that comes and more common ones is mostly we think about the weight gain rather than the gynecomastia first, actually. I hope you understood actually. Then also, of course, we know some of the extrapyramidal side effects. All right, extrapyramidal side effects. Great. Also in the right hand side, one line which I want to add. This is also blocking some of these receptors. By blocking this receptor, it is causing galactoria. Blocking this receptor eventually, they're blocking. So dopamine antagonist. So dopamine is opposite to prolactin. That's the prolactin increase and galactoria. Doesn't mean that is gynecomastia. One another line that is, it can also, like, just to add, it can also affect the alpha receptors, H1 receptors as well, right? I will teach you guys more these things in the psychiatry, especially that we have a separate section of the pharmacology. Great. Now, caution, in caution, actually, increased risk of stroke in elderly. So this is something additional and something new we should know about the respirator. All right, guys. So understandable, everyone is agreed now, with that particular one, the weight gain, so we're not going for this one actually. That one, this one, and this is not a common side effect either. Okay, so galactoria is a very common side effect, but gynecomastia is not a common side effect. Okay, so we need to get out of these things actually. Yes. All right. But if question comes regarding gynecomastia and if the drug options are there, then you can consider those drug things. Very clear, guys, actually, about this question. Is everyone is clear? I mean, then we can move forward to the next one. Yeah. I mean, it's not a very difficult question actually, but some of you, give yourself a very nice bamboo, actually. Very good to see that actually. So today in the very beginning question, this has happened actually. I mean, yesterday performance was very good, but today in the beginning, looks like, many of you received a very nice bamboo. So it's a good morning bamboo. So let's go and, go with some of the things. Now, this is I take as a nutshell from some different reports. It's sometimes tested clozapine can reduces Caesar threshold. Regarding this one question in past we have seen, yes, like this one. Also very, very important. Clozapine is a very good drug, guys, to be honest, but it has a problem of a granulocytosis. That is one of the reason for clozapine. We do what? Can anyone mention in the comment section if you are using clozapine, even though as a last resort, what thing you need to monitor? Something you need to monitor weekly. Something you need to monitor weekly, and that is CBC weekly. Monitor CBC weekly. Well done, guys. Good knowledge. And of course, learn a lot of things about the olanzapine. You can also go to the guideline group and search with the word olanzapine, and you will find a lot of questions related to olanzapine and try to solve those questions as well. All right, so olanzapine, metabolic disturbances. Okay, so these points are given. You see in another anti-psychotic like ziprasidone. Ziprasidone can cause arrhythmia, prolonged QT, basically they can cause prolonged QT. Thyroidazine, cardiac toxicity, and also can cause retinopathy. Okay, thyroidazine causes retinopathy. Yes, and also chlorpromazine, just to add corneal deposit actually. Yes, so these are some of the additional points which we can add, for you. Okay, so we'll talk, as I said, is more things in the psychiatry, don't worry, but here's some of the information. If you want to read more about the antipsychotic drugs, initially you can start with Kaplan, but still you need to solve a lot of riddles. Moving forward, and I'm going to show you some of the summary charts. Yeah, so that can be useful. You can take a picture or whatever, or you can write down. Writing would be difficult. You can take a picture, would be good for this section. See, typical and atypicals. Of course, atypicals have less side effects. Typicals has more effects, but more side effects. Actually, that's the thing. Example, haloperidol. Haloperidol is a drug. Of course, it has good effect, but at the same time, it has a lot of side effects. Okay, so you see extrapyramidal side effects, EPS, which I will show you very soon. Like EPS has another 3A or 4A to remember, which I will tell you shortly. Hyperprolactinemia, anticholinergic effect, anticholinergic. Then thyroidazine has eye-related problem, neuroleptic malignant syndrome. So very nicely precised everything is given, and there are atypicals actually. And in the atypical C, what is the first thing that is written in the atypicals? What is the very first thing that is written? So I gave you two references, to be honest. So this is atypical. Will you agree this is atypical? Yes. Also, do you agree, which one is the common side effect? So hope you can see that. Is it mentioned anywhere like, gynecomastia as a common side effect? Not really. So weight gain, then, arrhythmia related or rhythm related problem like ziprasidone can do that, or some of the others. And if you're using clozapine, agranulocytosis. So these are the things you need to remember first. Okay, and risperidone is a very good drug, one of the first liners among the atypicals. So you also need to know everything about that. Great. Showing a different chart. Okay, this is a mood stabilizer chart. You can just keep it to you as a bonus. Sorry, it's a suddenly mood stabilizer came up. Not discussing this, but maybe you can take a picture of this one so that you can use it later. Useful, definitely useful. Some bipolar cases, of course, we use this mood stabilizers. Next one is coming. As you can see, extrapyramidal symptoms. And so this is the thing I was telling, that in a lot of A you can tell actually. So if things are happening within minutes, so this is the thing. I can add this thing from my experience, like I'm not sure I shared with you guys during neurology, that just after internship I joined as a medical officer, and of course a lot of charge inside that time. So, always, wanted to make an exceptional diagnosis and the thing. So one day a patient came, and the patient is in like kind of like this shape. I was telling my CA that, what do you think? But I think it's a case of tetanus. And, he also get biased to, seeing my confidence. Then we decided, okay, since professor just after round about to go home, let's just ask him actually, because it is his day of call. So we just went and said, and he was smart. So he said, like, doctor, there's a new patient, maybe you need to see that one. And, I overstepped and said, I think it's a tetanus cancer. And he just looked at me, tetanus. Okay. So I immediately understood I'm gone actually. Now he came and he just asked one question. Did you take any drug for vomiting? And now the patient party, but when we were asking, they were not. And we are not also convinced, we are thinking this is tetanus. So what happened there, guys? Why that person is in that kind of shape actually, and which drug is actually is here? Which drug is actually being used here? Have you heard this name that, Stemetil type of drug, which also can be used in case of vomiting, but it is also at the same time has extrapyramidal effect. In order to solve that one, we given another drug, parkinil, to balance the effect. Actually, of course, some pharmacist given, and then he didn't give the parkinil, so he had this side effect. Okay, so this is the thing that happened, and this extrapyramidal. So that was a very classic case of this thing, acute dystonia. That was a very classic case of acute dystonia. Okay, so it happens immediately. So if for acute, then akathisia, akinesia, this one you can write as akinesia as well. Okay, so this is like in minutes, like very immediately. In first it can happen, so days, 2 weeks, this A, then like months, it's like echinacea. Few months is tardive dyskinesia, almost takes like a 6 months. Like if you type tardive dyskinesia in the YouTube, you'll see someone who is smacking their lips, a old lady smacking their lip. So that is tardive dyskinesia. So that means stopping drug now, but still it can happen after 6 months. So that's the tardive dyskinesia. So that's why drug history is important. So these are some of the A's, like acute dystonia, akathisia, dyskinesia, tardive. Remember one thing, in the main exam they will also ask you uh, the step of managements. Actually, example, this akathisia, akinesia, relevant. They also play a few things, actually, like when to stop the drug, when to increase the dose or decrease the dose. So they try to play with you in the management. So keep it in mind, actually. All right, let's move forward. Let's not waste much time. Now here is a question, actually. 9-year with a snake bite after 2 hours, no elastic bandage. What is the next step of management? Now that's an interesting question. What do you think? Okay. Recently, I have seen more ortho question coming. Also, I saw one too. This level of snake bite or poisoning related question started to come. There's another poisoning question come, which I will show you very soon. Okay, so many are thinking, referring, because the person brought to the hospital and the person has no symptoms. Okay, now that's a good thing. Now, is it right to go for a option C, swab for a venom test? Do we do that really most cases? Since it's a asymptomatic case and the thing, what is the best option here, actually? But which one do you think is the best option here? Okay, a lot of things are coming. Some says CBC, some says urine analysis, some says E, refer to the tertiary level hospital. Yeah. Now, there is two things I would say. One, you need to consider this thing. If you have option of testing this can be one option, or urine maybe little later, not going here, because if there is any anticoagulation and things, that is something we can keep it in mind. Okay, next thing, it is also very important that referring to tertiary level hospital. No, by the way, maybe the place we are talking about probably has antivenoms. You see, when it is given in the option, it is already antivenom. But unless sign of envenomation, we call it sign of envenomation. We usually don't give any antivenoms. Actually, there is some universal antivenom. We don't give it unless there is something significant. Swab for antivenom, this is like nothing much significant here. Now, patient does not have any symptoms. Came after 2 hours. So came after 2 hours, no symptom. First of all, what do you think? Do you think it is a poisonous snake? My first thing that comes, was that a poisonous snake? It's been 2 hours. since the bite. So can it be poisonous? No way. If it's poisonous, the snake in 15 minutes, the or even in depends on the things, a lot of things can happen. Now, I don't think so. It's relevant, so we can exclude that one. So the best thing, for me is actually, I don't know, somehow it's missing, or I'm not sure the recolor has flipped some option or not. Best way is to observe. What do you think, guys? The best suggestion is observation in the same place, because patient does not have any symptoms. So I've seen some of the guidelines again, just for this question. I found that it does not have any symptom, even if it's a GP center. They have some other drugs too, but they just observe that one because it's been 2 hours. So it is not supposed to happen anything at this point, actually. Now, if that option is not there, yes, that is the correct thing. We like to observe for a few more hours. That's the main answer. But since it is not there and they are offering you refer to tertiary level hospital, maybe you can do that. Are we clear, guys? I mean, since it is not there, maybe we can refer to tertiary level hospital in that case. Better you just refer in that case. CPC, it can be done. I mean, to at this point, to further testing and the things, that can be a good option. But with this kind of question, often we have seen, referring to big hospital is actually quite makes sense, actually, referring to big hospital. So keep it in mind, as I said, it can be very close in between A and E, the final answer. No, actually, we definitely want to see. But the thing is, since does not have any further symptom and thing, so maybe we can just observe for a while if that's given in the option, or either we, okay, you go to the, because imagine if it's you in Australia, if a snake is biting you and you are in the GP center, what do you want to do? Yeah, so they'll tell, is am I okay, or can you send me to a better level of hospital and the thing, or what if some changes happens later. Now, because some of the venoms act later, it's a possibility. You have seen, like, heart and some of the other things, seizure. So some of those things we need to keep it in mind. So since your patient is asymptomatic now, better you send, and better to be in the safe side. You got the point, guys, in this case. All right, great. So that's why we are picking that option as a refer for this question, since they're offering us this option. All right. Next question, a little controversial, last one, that's okay. A 32-year is brought to the hospital and collapsed. He's taken her grandmother some white tablet that is mentioned. ECG is given, what is the cause? All right, many are going for A, I can see the answer, and many other is also following, because others are going also for A answer. Not bad. Okay. First of all, let's come and see this ECG interpretation. Who can tell? I mean, many of you are very good in interpreting ECG. What is this ECG finding? I'll come to the answer. What is this ECG finding, first of all, guys? Do you have any finding in the ECG? Okay, we can see one thing clearly, that is tall T, probably. Now, what is tall T is an indicator of, actually. Now, just by one lead, can we declare something as a MI or something? Because it should be like lead specific, right? Yeah, like for to consider MI, it also has to be, a few things like lead specific, if you are considering that in some way. QRS, some people are saying with white QRS, probably. I don't see that much white QRS. This area, I mean, let me zoom first. What do you think? Okay, some people say PVC. PVC. Okay. Okay. So one thing that is evident, that is tall T wave. First of all, that is evident. Now, second question that is coming, can anyone confirm me? Is there any bradycardia in this ECG? Next thing, please confirm me if there is any bradycardia in this ECG. All right. So I take those notes from here and think in this way. This is a 32-year person who was collapsed because of taking grandmother's white tablet. Now, do you know the color of some of the white tablets? What is the color of digoxin tablet? What is the color of vitamin K tablet? So answer is, or there's like another imperial tablet. So answer is, both cases it's white. Both cases they are like white tablets. All right. Now from the tablet size, you really can't really differentiate. Okay, some drug formulation color can be different. Just to, because of the history, some drug companies changes the color just to avoid confusions actually. All right. So digoxin and the potassium, these are the two things. Now, both of these cases are associated with hyperkalemia. Will you agree on that point? Both of those cases, what do you think? Associated with hyperkalemia. Both digoxin, both potassium. What do you think? What are the causes of hyperkalemia? Now, if you check the drugs, all right. So both can lead to, I guess some of the doctors are a bit confused, others are not responding. Forget about the C, come in between A and B. I mean, performance from cardio looks quite shocking from some doctors. But how about others are not responding? Some of the doctors are not responding at all. I'll ask individually, guys, then to turn on your video and mic if you guys are not responding. Yeah. So here is the thing. I think it's said. I think it's not. Yeah, it's potassium tablet. It's not vitamin tablet. Actually, it's a potassium tablet. That is correct. So digoxin tablet and potassium tablet. So if we consider in between these two, digoxin tablet and potassium tablet, then which one do you think is better in that case? In our country, potassium tablets are white. I mean, it might vary from country to country. But that's not the point. I mean, that's maybe beyond some doctor's level. Okay, so this one I'll count. I was just wanted to check. I think I found that this one is beyond reach for many of the doctors actually. Okay, let me give the explanation. Okay, this one's answer is not vitamin K, sorry, it's a potassium tablet. Yeah, let me just cut this part. Potassium tablet. Now, why we picked the potassium is just because of the tall T wave? Not really. Reason, let me tell you why we didn't include the digoxin, which is also a very classic in this case. In case of digoxin, it's not only the potassium level is up. Okay, so not only the potassium level is up, but we also expecting sinus bradycardia. Now let's go back to this one. You said, some of you said PVC, but both of the cases can be PVC. Was there any bradycardia? Can we double check again? Was there any bradycardia in this case? So digoxin causes bradycardia, which is very, very common in digoxin cases. So this one doesn't seem like that kind of bradycardic cases, but certainly there is tall T wave and the thing. I think because it's a collected ECG, I mean, they will give you a more clear ECG with just tall T wave, they will show it. So in that case, you will only find the tall TUF, you will not find bradycardia. But if you find bradycardia in the option, then it will be decoxing toxicity. So guys, are we clear with the answer? Are we clear with that answer? Now, actually, why we didn't picked up the uh, that decoxing? And I can tell you one thing from my experience. This question is a old question, not a new question. This question is been previously there, I mean, in AMC, and we picked up this thing as a potassium tablet. Right. The main issue to consider here, if you see, to tell something as a digoxin toxicity, there has to be tall TUF, that is for the potassium. I mean, potassium digoxin also can raise potassium level, but there has to be sinus barrier. This is one of the differentiating point between these two. Right. I'm not very sure was it there in the cardiology class or not. Is this concept was there in the cardiology class? I'm not very sure, but that's it. Okay, so but some of you may be registered and absorbed it. That's okay. Going for the next question. Patient comes with dysphagia and history of asthma since childhood. Cousin has eczema and endoscopy showing narrow ring. So in these cases, and biopsy has been done, some listeners will find what is the appropriate treatment for this condition. See, one thing you guys see, when questions are mixed up, because today some of our theory doctors also joined, but performance is so shaky. In some of the other days, you guys are answering confidently because this is a question related to respiratory, this is a question related to IENT. So now many are shaking while answering. Now you understand the difference, guys. Why you need to practice more randomly. It is very, very important in this case. Now, here we go with the answer. What is the diagnosis? So first of all, let me reveal the diagnosis from my side. The diagnosis, or otherwise some other can tell, diagnosis is eosinophilic. So that's how they wrote it. Actually, I've seen in a lot of articles even eosinophilic esophagitis. That's how they wrote it. And what is the first line of management? Let me tell it from the what is written in RSCGP and some of the other. It involves avoiding the relevant food, and giving corticosteroid therapy. Okay, significantly impair the quality of life, and that's another possibility. So avoid triggering those are food related and corticosteroid therapy. So reference RSCGP. So we picked up the option, this thing, budesonide. Most appropriate treatment has been asked. Most appropriate treatment has been asked. Right. So this is eosinophilic esophagitis. Eosinophilic esophagitis. So therapeutic good administrative therapy, yeah. So we also checked with the another guideline. It was that budesonide is one of the therapeutic choice of treatment in Australia. So are we clear, guys? So we use two references. So sometimes double checking with the references. One, if it's a book reference, one is a journal reference, and if Australian journal reference, it's more better on this. Okay, so this is, we are fully sure now that this is a case related to eosinophilic esophagitis and steroid to start. Now, along with steroid, we also give PPI. Please keep it in mind. Along with steroid, we also give PPI because steroid itself can cause a lot of other issues to the stomach. Next thing is coming. Infertility scenario, and a man who is normal female with a prolactin level. Because infertility cases, next question is coming, guys, before going into that one. In an infertility case, whom to test first, male or female? In an infertility case, whom to test first, a male or a female? Answer, it's a male to test first, especially semen analysis. So then, we consider doing other tests for the female. Now, what are the tests we do for female in case of an infertility case, guys? So someone is trying and not happening. So in infertility, let's start, with the female cases. So in female cases, what additional test you want to go with from the beginning? Let's start with FSH, LH, thyroid stimulating hormone, and also you can check the prolactin things. These are the things. And also later ultrasound will be included into that. Okay, so this is the way of investigation. Yeah, then we'll go for the ultrasound thing. If prolactin comes positive in certain time, then we can go for MRIs, okay, just for more records. Now, like this is given, prolactin level is elevated. So they can also ask you, like, if prolactin is elevated, then what is the next test? So I'm just clarifying that one. Like question, they can twist, and this is how they twist. So if prolactin is elevated, the next thing we like to do is an MRI for further confirmation. Now, we have a prolactin level, and this is actually given in nanogram. People didn't remember, but let me tell you, this is usually mentioned in nanogram. So 5,500 is mentioned. Now, what do you think about that? Like, is it because of a drug, tumor, or yeah? So this is quite a high. This range is quite a high, and this is, as you can see, this is more than 4,000 is a pituitary tumor suspected. If it's less than 4,000, like it's given in the question, like 1,000 or 1,200, then it is actually drugs actually. So this is too high, guys. So this is a tumor. This is a tumor. Now, a very quick question. I'm sorry I asked too many things. What is the first line treatment for a prolactinoma? If it's a prolactinoma, what is the first line treatment in this case? Okay, surgery and medicine therapy. So we go for a surgery or go for a medicine. That's the thing. Now, since it's a prolactinoma, even though it's a pituitary tumor, normally it's supposed to be surgery. But prolactinoma cases, if it's prolactinoma, we go for drug. This is one exception. So take note, guys, all the prolactinomas or all the pituitary tumors, we go for surgery as a first line, according to Davidson's medicine. We go for surgery first line, except for prolactinoma, where the first line is a drug actually. What drug? The dopamine, dopamine agonist drugs. Okay. Example, bromocriptine, cabergoline, quinabolide. Bromocriptine, cabergoline, quinabolide. These are the things we do use in this type of cases. There's some little notes for you guys, maybe can be useful for some of you at certain point. Now, indication for neurosurgery in prolactinomas. They always look forward to something new because we all know it is answer is drug. So you should also know that when surgery is indicated, and this is the things, guys. This is the things where even in prolactinomas, surgery is indicated. So I believe this question hasn't came, but in future they will ask this thing definitely. For example, dopamine agonist. That means they tried a drug and it is failed. Dopamine agonist resistant macroadenoma. Yeah, so drug failed cases mostly we can see. Also CSF leakage, like the second last option, CSF leakage you can see during administer of the drug. Pituitary apoplexy that is mentioned. I can also add in another red flag. If it is causing any vision issues, that is also a red flag. Correct, guys? If the prolactinoma also causing some vision issues, is that an indication for surgery as well? Yes, that's also a yes. It's a red flag too. Great. Hope it's understandable, and it was a very interesting question. And as I said, because I know the pattern, a lot question tested from 2015-16 these days. So guys, we'll just go for a 1-minute break. Initially we just cut down. I mean, now we're going to cut down the YouTube version. Actually, we are also going live in the YouTube. So let me just cut down the YouTube version now, and we'll just come back after 1 minute. Thank you. And we'll continue the class definitely. Yeah. All right, let's keep it be, not a problem. Let's keep it be. So we'll be just back in 1 minute, guys. You guys keep thinking about this question. Okay, guys, let's continue from here. Great. So I have to check a lab report of my father actually. So he was just texting me about that. Okay, great. So guys, let's go with this question. A case of community-acquired pneumonia was treated and got well on the day 3. On the day 5, the patient started having fever, chill, rigor associated with basal pneumonia associated and IV line associated cellulitis. What is your probable diagnosis? Now, first question, can it be hospital-acquired pneumonia? My first question, can it be hospital-acquired pneumonia? If it is no, why it's not? Okay, we are saying this is not a hospital-acquired pneumonia. And is there any timeline for hospital-acquired pneumonia? So more than 48 to 72 hour crossed, more than 42 to 70, yeah, 40% are crossed actually. So it is not a, so this is always, please clarify and remember this point. This type of question quite common in the exam. So please keep it in mind that time zone, what days are mentioning today. Okay. So that's out. Now pneumonia and things like, but do we have, it can be also uh, the typical pneumonia, of course, but where is the main source of this one? They have a spatial line here, IV line associated cellulitis. Is it possible IV cannula related this organism has entered and then traveling? So that is very high likely. Is it a very uncommon thing in practice? Imagine, your intern days or your current practice. Is it an uncommon thing? I even my internship, I've seen this when I was medical officer. I've seen this. It's quite a common issue, right? In IV cannula based bacteremia, then it entered some places, very widespread in the hands. It can be very dangerous actually, right? So it is highly recommended not to keep the cannula set for longer time. But still, if you are using it for shorter time, still that thing can happen, like through the pores of the skin or an immunosuppressed condition patient. It is possible actually. So we'll quite sure the answer is D here. So IV cannula bacteremia, this is our final answer. Yes, and this is a little reference actually for why this is IV cannula based actually. And this is some of the associated you might find fever, tachycardia, hypotension if IV cannula based. Some cases, and IV cannula based can also lead to septicemia or sepsis, even death. It is a possibility through the gram-negative bacteria. Anyways, so this was the question. We choose D, and we are going for the next question. Okay, now this is the next question. Let's me read out the next question for you. A 42-year man, 40-year man with a headache, nausea, vomiting for 2 days. Under treatment of heart failure now has hemiparesis and irregular pupil. Patient CT scan is done. What to do next? Okay, that looks quite a fine thing here. So irregular pupil is not a good sign. Whatever it is written here, this is not a good sign. So what is your plan? Tell me. Hemiparesis, nausea, all these things. So what is your plan here in this case? I mean, if you are a neurologist or neurosurgeon, what is something to do next? So this is a case of a stroke, that is quite sure. Case of a stroke. I think this is not pulse, guys. I think this is irregular pupil. It should be. Okay, it's not a cardiac. It's just clarifying, guys. Sometimes this is a problem with the recallers. Is it anywhere looking like a cardiac case? Somewhere. Not really worried. Okay, so it's irregular pupil, guys. Let's count as irregular pupil. Because when they're using this word hemiparesis, they will use another neurological term, right? So irregular pupil, let's count as irregular pupil. Then let's just go forward. What to do next for this case? It's not a good sign, irregular pupil. So CT scan, which is done as well, and CT scan has a stroke finding. Now, question is actually, we're not really thinking about subarachnoid hemorrhage and the things like that, right? So maybe, or not a meningitis case. So maybe it's not a lumbar puncture. Can we rule out the lumbar puncture from here? Yes. So maybe we can rule out the lumbar puncture from here. Maybe we can rule out the echo from here. We are counting this one as irregular pupil. And now there is a thing, a duplex, carotid duplex. If this is a case of amaurosis fugax, I hope you know this name, amaurosis fugax, like sudden vision loss and then it's restored. Then my answer would have been, this carotid duplex. Am I right? If amaurosis fugax, a sudden TIA case, then carotid duplex is fine for me. Next. Also, it's very common in very elderly cases, isn't it? Example, 70 years, 75 years. They have already carotid stenosis. This gentleman, on the other hand, is not that elderly person. Next two options are remaining. We are using a method right now, which is called the exclusion method. Exclusion method. Now, as you all can see, that CT angio and MRI, these are the two things. So 40-year headache, nausea, vomiting for 2 days with hemiparesis and irregular pupil. So in that case, what to do? So very ideal it would be to rule out the further things, what is really going on is CT angiogram. The ideal here is to actually what to do next is always it is better to do CT angio in these type of cases so that the neurosurgeons and the thing they can also take some more further things here. I'm just taking the screen for a second. We'll come back just in a second. So remember this thing, this is always significant if can be used CT angiogram that gives, you know, the neurosurgeons some more guidance. Neurosurgeons some more guidance towards, you know, right arteries and which exact part is involved actually. That's the thing. Echo, I mean, echo you can consider if it's more over like a cardiac case. I mean, it's your need, you know, if you feel like, you know, right now you need the echo more, you can go for echo. That's the thing. Yeah. But cases indicating more towards the neurological, right? So if it's echo, you know, you can go for later. Yeah. Not a significant question, okay? Not a smart question as well. All right. Now, next coming is an ankle joint injury. Ballet dancer fall on the stage after splitting. I hope you know they do a lot of type of, this is a game in the Olympics and the thing. So mostly for ballet dancer, we learn about the foot related, mid-foot pain, foot related injury. These are very common, right? I don't know how they do that. Anyone here, I mean, no gymnastics? I'm not sure. Or ballet, whatever. Okay. One time we found, you know, one doctor, you know, she knew ballet, you know, wow, long back. That's why I asked actually. Now, the question is, you know, what do you do next? Why she fall down and what to think in these cases? Okay, many are going with bone scan and DEXA scan. Okay, so why is the reason people considering DEXA scan? Why people think answer is a DEXA scan actually? Okay. Now, ballet dancers are normally quite young. Yeah. Now, of course, you know, over 50 ballet dancers are common guys, you know. So, okay, let's say it's a 25-year ballet dancer is, you know, dancing on the floor. And after splitting, this thing has happened. Okay. So now what do you think actually? Can it be DEXA? Can it be electrolyte? Can it be? Yeah. You know, you need to focus on one thing. What is the reason of fall down? A ballet dancer, maybe they just, you know, take a turn, you know, like hook turning or doing some splitting, as like the person is doing, it's called the splitting. So after that, she fall down suddenly. Now, why it happened actually? Nothing mentioned about previous head injury or something like that. So we cannot really go for head scan. Now, question is for doing CT scan, is it indicated here? Still, is it indicated here, the CT scan, without any head injury, without any, you know, certain vomiting, something? Can we go for the head CT? Okay, if she falls down and then injured her head, then it can be a reason. Otherwise, you know, we give a cross here. Now coming to the vitamin D. Why she will fall down because of vitamin D? She might have bone pain and all this thing, but those are thinking as a C. It's a, yeah, yeah, it can be, but you know, not they will fall down or the things like that unless you are thinking about the tetany. That's, you know, will be related to calcium level, not a vitamin D level, right? Not like a vitamin D level. You know, it will be direct like hypocalcemia, tetanic. That's a different thing. But they will tell you about tetanic features, not like this, not like this. This is like total. Now, two things remaining: DEXA scan. Now, some of you are thinking like maybe osteoporosis things are there, bones are becoming weak, and maybe the bones is broken down. This is a young, you know, lovely person. It's quite unlikely. Now, I'm not sure how many of you been a sportsman or a sportswoman. Uh, why a sports person fall down? What can be the reason? It's very common, you know, it can be two things. See, many countries are cold country, so dehydration may not be issue. But if it is a hot, humid country, dehydration can be issue. It can be also over practice, not eating something, vasovagal syncope, electrolyte disturbance, and all these things can lead to. And because ballet is a tough thing and they practice a huge a lot, so over practicing can lead to dehydration. That is a possibility as well. All right. So over practicing or maybe or not eating before the main event, they're stressed out often. So that can lead to this thing happen. So anything like imagine in neurology when I tell you guys about the seizure thing, if it is happening for the first time, what is the first test you need to do in that case? The first test what you need to do is, electrolyte was there. Okay, so this type of fall down, why lose balance and fall down, that's the thing. It's hardly they usually fall down. Actually, if fall down, maybe some reason is there. Actually, if sleep, that's a different thing, but fall down, so this is can be because of the electrolyte. And electrolyte is a big list of electrolytes. That's the thing. It's very logical explanation, guys, like they fall down. So often after long practice session, it's very common during the main event, it can happen. So RBS in the first, unless there is a head injury. If there is a head injury thing is involved, then you can go for CT scan. As either it's a electrolyte. Now see, a easy question. Many of you, give yourself a own bamboo actually here today. This was supposed to be easy one. Now, how many of you have received this nice bamboo by self-given bamboo actually? Yeah. But I think the explanation is logical. Sometimes, we just keep thinking, it's AMC. Definitely, they have something suspicious answer. That is also one of the reason many people choose, DEXA, many people choose. So, guys, it's always not the very difficult answer they choose. Sometimes they also choose the logical answers actually. Okay, so that is the problem sometimes happen because they have tough questions and also mix of easy question. So we just need to be careful on that. All right. Next coming, yeah, very typical with the ballet dancers and the thing. And maybe this article you can read a little bit. Let me share this link with you guys. You guys can read, like, what are the injuries can happen. This is not exactly related to this question, but from the orthopedic point of view, you should also know, what type of injuries can a ballet dancer can receive. Okay, so the mid-foot pain and that thing, as I said, like it's not directly related to that previous question, but they can twist a lot of question, and with valid answer, more question can come in future actually. So I just shared that article. Please read that article once. Okay, here we go. One more question is 23-year young man with having a weakness of small hand joints and pincher grips and loss of sensory palmar aspect of fourth and fifth hypothenar. So fourth and fifth, sorry, fourth and fifth hypothenar. Okay. What is your probable diagnosis? Nerve entrapment in elbow, T1, T8, carpal, sorry, it should be tunnel, is like mistake, tonal, carpal tunnel syndrome, radial nerve. Now, what do you think is the answer? Is it because of median or is it because what do you think about ulnar? Now, please clarify me that thing. If your fourth and fifth is involved, do you think, what do you think? Hypothenar, hypothenar. And also pincher grasp. Yeah. So this is more over like an ulnar nerve. So if it's the ulnar nerve, it's not carpal tunnel in any way, right? So what we have is I'm going to explain this one. Yeah, so it is known as cubital tunnel syndrome here, actually, cubital tunnel syndrome. Nerve is entrapped, the ulnar nerve comes through this part, so that can be involved. So cubital tunnel syndrome can be involved. Now, what is the consequence? How we can really differentiate between these two? Carpal tunnel, both are like CTS, like, carpal tunnel syndrome, and another one is a cubital tunnel syndrome, you can see. Now you can see this, like the main carpal tunnel is in the nerve that is median nerve affected in carpal tunnel. The nerve compressed, that is median nerve here. The nerve that compressed is a median nerve here. Nerve that compressed in that fossa, cubital tunnel, is a ulnar nerve. Now that's the main basic difference. Now come to the carpal tunnels. We all know thumb, index, and the middle finger. Thumb, index, and the middle finger. These are something that is effective and part of ring. That is the carpal tunnel, medial nerve. And also there is a special test for carpal tunnel. Okay, so if you tap over that wrist part, just you can also aggravate the pain. And also some pre-existing thing like pregnancy, acromegaly, this type of features can be there with carpal tunnel. Keep it in mind. And symptoms are given in of carpal tunnel as you can read: numbness, tingling, wrist pain, yeah, hand weakness. These are the things. And now cubital fossa. Cubital fossa, ring and the little finger, which is matching our question. The ring and the little finger, yeah. And also weakness, tingling, these are present. Pain is often can be present in the elbow and may worse on the elbow bending. So in the main exam, when you will go, these features will be also there actually. Maybe the recorder didn't remember all the points, but in the main exam, you will also find these points actually, because those questions will be 5-6 lines long actually. And normally when we receive the question, it's not much because it's just like cracked version. So many points are missing. So you need to read and study these two things at least very well, guys. You need to read and study these two things at least very well. I hope that's understandable. And of course, like from where I use the reference is given below as a link. Okay, moving forward, I hope it's understandable. So carpal tunnel and cubital tunnel. So cubital tunnel is a new another orthopedic topic. Previously, a topic which we touched very recently, iliotibial band syndrome. Okay, so this was, I think, I hope you guys are familiar. Now, please respond in the comment section if you are familiar with the iliotibial band syndrome, which I think I taught just few days back actually. Okay, so that was also a new question. So we can see nowadays almost 6-7 questions from orthopedics, and some of the questions also started to coming from poisoning. Guys, like previously, a lot of questions used to come from poisoning. Okay, then in between they stopped asking because poisoning is a very standard chapter, and from poisoning it is supposed to question come, and it is actually answerable question rather than some extreme ethical question. It's very difficult to answer sometimes actually. And my point of view, one thing that sometimes when a country required uh, more doctors, I mean just my personal observation, country required some cases more doctors, they make the question easy so that more doctor pass and can apply. When they don't need more doctors, they make it difficult. All right, so you got my point, what I want to say. Suddenly we can see poisoning question because these are answerable question, and extreme ethical question, you bring a professor, he will also fail, in AMC, 100%. Because some of those ethical questions, no one can answer. Even if you take me, maybe from experience, I can answer few, but I also won't be sure with some of the ethical question because it's every time new something, some of the ethical questions. So if someone wants to make someone fail intentionally, in that case you can give more ethical question, more population health question, and that they were giving actually in between, especially in 2000, I would say 2019, yeah, that time actually, to the end of 2018, 2019, also beginning of 2020 we saw. Now suddenly we saw that little wind of change, and they started giving and involving all the chapter, which is they're supposed to like involve all chapters, like equally nice question, orthopedic question, INT question, poison related question, and these are answerable question rather than some extreme hard psychiatric question. No one studies whole DSM-5 unless a psychiatrist. Even psychiatrist, some of my friends are psychiatrists. When I send them some MC question, they said, "What is it, man?" Actually, they also don't know few of the things. That's creepy sometimes. So some questions are just like a trial question. So that's sometimes confusing in MC. Now we can see this is 2020. In last 2 months, our 27 doctor got job. This has never happened. This rapid, thing. It's like, I was feeling like, I'm receiving results. Previously we used to wait, when someone will get a job. Now, just keep coming, like doctor, I got matched, I got a job. So it's a golden time, guys. At least 2022, at least the golden borders open. They need doctors, and you can see in Indeed.com, this is full of like advertise of like, the doctor needed this place, that place. And guys, one thing, it's ideal to get into the pooling system. I'm sure you don't heard about this term. Pooling means what? Pooling means get into the system. If you know some HR from the beginning, and even if you're telling you are preparing now, that's also not bad. Okay, like keeping in touch. Maybe some of the HR you keep in touch from the beginning, and then when you actually pass, and then say, yeah, now I pass. Can you just give me a job? Can you arrange an interview at least? I'm good with interviews. You need to sell yourself. You need to convince them, like you are good and the things. And in turn, actually, this thing happens. Actually, many I can tell from the history with many doctors, which I talk sometime the same thing. They all said one thing, that the maximum number of application is important. Some people has a feeling, okay, when I'll just pass MC1 and 2, the job will come to me. Okay, I have experience of 4 year in ICU, and I'll pass the MC1, I'll get the job very easily. If you don't apply, how come you will get a job? Be logical, guys. So make a start with opening an account in Indeed.com. you know So this one, that, and there are more videos of mine. There's more um, things given. Then JMO campaigning. But for typical JMO campaigning, you need to pass the exams, and you need a more solid preparation actually. But through the Indeed.com, they just advertise. Just get in touch actually. I also can give you an example. One of the doctor, she was driving actually, and a call came from HR and asking what you are doing. Are you free? She says, I'm sorry, I'm driving, but I can talk, because it's a first call from a job from a Darwin area. Then the person just had a conversation for 10 minutes, and he just offered her a job. She just she was a little shaking, and she don't know what to do. She just called me suddenly. Okay, I received like, doctor, what happened? Doctor, there's a call. Suddenly, I emailed previously and then call, and 10 minutes. Is this a scam or is that a job? No, that's a job. Yeah, so it can happen, things like that actually. So it's all about convincing. And maybe that HR also have seen that she knows how to drive. She's already in Australia, she has cleared her MC1 and the thing, and she looks confident. That's the thing they want actually. It's not like a two high profile professors things they don't look forward actually. All right, so this is the thing. uh, you guys need to keep it in mind. So apply first. Okay, so this is very important, guys. Apply first. It doesn't matter. You make a portal in Indeed or some of the things. Keep applying. You will receive a lot of email. The thing, if you choose physician as an option, any physician job would be there. You will receive an email on that one. Okay, great. And keep trying harder in 2022, maybe also in 23 as well. I mean, that will be remain, I think, in demand actually. And some people, tell a bullshit thing. Job is not available in Australia. Just open Indeed.com, and you check just you can see how many jobs are available. It's like lot actually. On the other hand, in between there was a period, there's so many doctors who are entering in UK. Now, very recently, because I'm a question modular of both AMC and PLAB, it was actually more easy question in PLAB actually. But nowadays, when I see the questions, I was telling them, in the beginning of this year, very soon they will make it a little difficult. And the sign is actually because um, initially it was needed during COVID time, Brexit issues. I hope you know what is Brexit issue. England is separated from European Union, and suddenly there is a lot of emptiness of doctors. So then they wanted to fill up it so quickly. So they don't check the qualification and everything that is strictly as before actually. So all they need is PLAB 1, 2 passed doctor. Okay, in UK you need at least PLAB 1 and 2, actually both actually. But for Australia, even with MC1 you can apply. So they just randomly took a lot of doctors actually, and question level was from the beginning, it was 100, 100, 100. But now it is when I see the questions, I was telling them, in the beginning of this year, very soon they will make it a little difficult. And the sign is actually because from the beginning it was quite easy. In between, I think I find it even more easy. But now I see in the last the exam month question, I found it was quite a range has been up. So what that is indicate? So it indicate also that they have taken the maximum actually. So from 2023, it will be little reduced the number in UK actually. Every country has a limit, right? It's not really limitless. Everyone is going towards UK. Yeah, no, that's okay. Actually, that doesn't matter. Yeah, I hope so. The discussion is helpful, and let's go for the next one. But all you can learn from here, that's apply quickly, finish the exam, and apply quickly. Yeah, you don't know your life can be changed in the next 6 months. Yeah. Next question. A 6-year baby with non-bilious vomiting, lab showing sodium low, chloride low, and potassium is low as well. Bicarbonate is increased, and what is your probable diagnosis? The question, important thing is mention non-bilious vomiting. That means it is coming from the stomach. Right? If it is a bilious vomiting, that means coming from the intestine. So it's high likely this is 6 weeks baby. We're expecting a little bit more, probably a little olive-shaped mass, but do understand one thing, olive-shaped mass is not always so common, and they also don't always give the projectile vomiting thing. Actually, this is will be the last thing to give in the exam, projectile vomiting. Okay, so your answer is actually pyloric stenosis. Check the age, check some of the other points, electrolytes. This is a very classic case. Yeah, I hope that's interesting picture. But anyways, what it is, yeah. So pyloric stenosis. Some of the cucumber look like this. Also, this type of pyloric stenosis. Sometimes, we have seen. I also remember I've seen a cucumber like this. I made it think that came. Okay, this looks like a pyloric stenosis. We have this habit. Okay, this one's shape look like this disease. This shape look like this disease. It's not bad actually to do little comparison actually. Yeah, because eventually you'll remember it. No worries, guys. So this is pyloric stenosis and little John Murtagh reference of pyloric stenosis. So 2 weeks to 3 months. So our age group was 6 weeks. So it matches. Then the vomiting thing. Always they don't give projectile because everyone understand otherwise. Yeah. So, and of course it is a non-bilious vomiting. Okay. So with that thing, it is a pyloric stenosis case. Pyloric stenosis case. And guys, it is good to learn the differences with the other DD. It will also help you in AMC part 1. It will also help you in AMC part 2 exam too. Okay, it's a very, very popular case, child with vomiting in AMC part 2. And you need to know the differences between how to differentiate with, say, ZERD, how to differentiate with gastroenteritis, how to differentiate with duodenal atresia. Okay, so if you get some time, try to learn them how to differentiate in between them. Especially with ZERD, a very key word I like to add, the baby remains hungry after vomiting. Now this point indicates pyloric stenosis, this point indicates ZERD. What do you think? Baby remains hungry after the vomiting episode. What do you think? This is pyloric stenosis, this is ZERD. So baby remain hungry, this is quite normal in case of cases like, what do you think? Okay, not. Okay. Okay, I won't give that answer. Okay, find it out. Find it out. I'll post it a little later. In my YouTube, I'll post it. YouTube nowadays, you can also post status and things. Actually, I'll post that one. Yeah, baby feels the same hungry actually. Yeah. I mean, just after vomiting, baby remains fine and baby, remains hungry. Baby remains hungry. Yeah, that's the thing. Okay. All right. Great. One answer pending. I'll post it in the comment section of the YouTube later. Actually, I hope you can see that one. I hope you guys know how to check the YouTube videos of the channel actually. So I'll give you guys a task to check the answer. I'll drop that answer there. Okay, so I hope you got the point there. So you need to know how to differentiate with the pyloric stresses, with ZRD, with duodenal atresia, double bubble sign, but there are more other things like, vomiting just after the birth. That is also a feature of duodenal atresia. Okay. Next thing, ECG, a 55-year-old male, with a chest pain and palpitations since last 2 hours. Vital is 90/50. Oxygen, aspirin, no TG, these things have been given. What's next? Now we have a ECG. So your diagnosis you have to make on the basis of ECG. Now, can anyone tell me what is the finding in this ECG? We can see a lot of palpitation. We can see, yes, and let's check the QRS complex as well. So it is ventricular VT, right? Well done. So well done, guys. So if it's that actually, and we can see one thing: is my patient is unstable? Is my patient is stable? That is biggest question here. My question is unstable, or we can say hemodynamically unstable. So here it's better we save the patient by a DC shock. DC shock. Yeah, that's the thing. It's very important. Like this is life saving. To be honest, um, the Olympics, upcoming Olympics, football tournament, the things. Example, Qatar. What they're doing, like even in the streets, even you'll find here that a lot of places, like this is defibrillator available in the streets. I'm not sure you have realized that, but when there will be a mass gathering, they will provide this sort of things, like the DC shock machine and the thing. How important is these things that saving the lives actually. All right. uh, because you must be heard a very recent incidence of a very famous singer, KK, I mean Krishna Kumar, I think, very favorite, I think, of many of ours actually. Many even don't know, lot popular songs actually sang by him, but they used to listen those songs actually. Now you see that, guys, unfortunately, uh, been forced a little bit by the, those who are arranging the shows, like they keep going, so he had to sing almost 20 songs. That means for a whole 1 hour, maybe, that is the golden period we call. He was singing that time, and he was in a theater where 7,000 people were there, and capacity was 2,000. So running short of oxygen, he's putting extra effort on heart by singing. So, all bad thing was happening at the same time for him. And he was feeling bad. He may be told that they will tell, of course, okay, two more song, two more song. Crowd is also cheering actually. So he's professional. He managed that, and that after that, he just left. And those idiots actually, they took him to the hotel rather than taking to a doctor actually. So he was driven to a different area, to hotel, and then from hotel, he was staying for another 30-40 minutes. Then he was taken from the hotel to a very central area. He could have been taken to any local hospital, and he could have been saved very easily by CPR, defibrillator, because his age is 53. With a 53 years heart, is very much stable heart actually, so could have been saved. So very bad luck, to be honest. Anyways, when actually the time comes, it comes actually. That's something it's been said. Yeah. Yeah, that's the thing. But still, in spite of the lack of ventilation, venue, he could have been saved. because there's another 2 hour that has been lost, which is golden hour, isn't it? Great. So this is DC cardioversion, guys. People can be saved with DC cardioversion. DC cardioversion. Actually, even in the large hotel when he collapsed, he could have been saved by CPR and DC cardioversion. Remember one thing: if you find ever any patients like this, consider a monitoring if it is possible. It can be your close one as well. So consider the monitoring. If you see rhythms not coming, give a DC shock and just keep doing CPR till taking the patient to the hospital. Yeah, patient can be saved even in that way. Okay, so this is a that's actually different. Laws can be different in different areas. Yeah, that's the thing. But CPR is a basic thing. I mean, if we talk in UK, Australia, you can't actually give CPR to a person. One person can give CPR to another person. So that's whole fine. Now you can see, guys, this PSVT, this chart is actually very important. One question is always confirmed from this one. If you can see PSVT, what is first thing? It is carotid muscles is first thing. What is second line? Adenosine is second line. If you have asthma, you can't give adenosine, then give verapamil. If nothing is working, DC shock. Our patient from the beginning is already in shockable state, like blood pressure is like a 90/50, then again you give DC shock. Same treatments given with atrial fibrillation, the second one. Your first line is metoprolol or beta blocker often. So control the rate rhythm, and then later you can add digoxin or vice versa. Often it comes with a thyrotoxicosis, this atrial fibrillation actually. So metoprolol is a choice. Please keep it in mind. Bradycardia related, lot of questions that comes actually, including the heart block. So first degree, you don't need much thing. Second degree, if it's significant, you stop the offending drugs. Offending drugs means like the rate limiting those drugs, like beta blocker, digoxin, you need to stop them. You also need to learn from, if there is ECG video of mine, you can see that one, especially how to differentiate morbid type 1 and type 2. It's very important to differentiate. And in morbid type 2, which is significant, you need to also consider stop drug and giving a pacemaker actually. And these pacemakers are initially temporary pacemaker. Now guys, if you're offered temporary pacemaker and permanent pacemaker, which pacemaker should picked up in the exam actually? Say example, if there's a third degree heart block and you are offered, what to do next? Temporary pacemaker, permanent pacemaker. You choose the temporary pacemaker first, then permanent pacemaker. Also learn the indication of some other permanent pacemaker like sick sinus syndrome, where you also need permanent pacing. And what is the management of general bradycardia? You don't need any management, just reassurance. This is also popular in the exam. So sinus bradycardia comes, heart block comes, SVT comes, atrial fibrillation comes. Some cases premature beats related ECG is given. Recently we have seen a question, premature beats related ECG. Now, what is premature beats actually? Is it significant or we reassure the patient actually? If your patient is not symptomatic, what you will tell the patient, by seeing at the ventricular premature beat? That's what do you think, guys? Others? I was telling you guys, I was reading a report of my father actually. So in between the break, so actually that was the one of those finding actually, like ventricular premature beat. So now I have to call him and reassure him. So he's a little scared actually, with some of those tests actually. Holter and things are done. Then one thing came that premature beats actually. So, but still have to be careful with few things. Yeah. Yes, guys. So this is like this chart is very important. Whenever you study cardiology revising, start with this chart. Start always with this chart actually. Also, like when you start the pediatric surgery, there is a chart is in like 1025 page John Morthack 7th edition. Like, there's a whole pediatric surgery things are given. So you start with those charts are better actually for revision purpose. Okay, next one question. Very commonly that comes in the exam. A scenario for diabetic ketosis with ketonuria. Hemoglobin A1 is 10 probably after passing 50 cc of urine, which is less actually. So maybe a bit dehydrated as well. So that's a possibility. What to do next in this case? I mean, it's quite easy. It's just diabetic ketoacidosis. Now, understand one thing, guys. Now you are seeing scenario of diabetic ketosis. You seems very happy, but in the main exam, they will tell you, okay, increased thirst, a bit comatose, sugar level is high. Now you have to make a diagnosis, and then they will ask you what's the next under management. So then, of course, it is a diabetic ketoacidosis, and management is IV fluid. We usually started with normal saline, right? That's the thing. So we started usually with the normal saline. So IV fluid, then we give insulin. Very interesting here, we give insulin IM 10 unit till like 10. So till the random blood sugar is still up to 10 millimole. Yes. Normally insulin we give in subcutaneous, but here it's still different. And in order to correct, when you give a lot of insulin, what happens with the blood? Any electrolyte abnormalities because of too rapid insulin? Yes, most of your potassium will go inside the cell. Like if this is the blood, so when you give too much insulin, potassium enters inside the cell. So this will lead to hypokalemia. Now you need to correct this one because both hypo and hyper is bad for her, right? So both hypo and hyper is bad for her. So in that case, you need to correct this thing. You need to correct this thing by giving injection KCl, right? Injection KCl, correct it in that way. So please learn also there's some other fluid related management. Those also try to learn. Example, if you're offered colloid and crystalloid, which one do you want to pick up? Colloid and crystalloid, both in the option. And a road traffic accident patient, we will pick up colloid, crystalloid type of fluid, crystalloid actually. Then a very popular one in the trauma that in the accident site, what to do, like, giving IV fluid first or secure the neck first. You will be, they will try to confuse you that. So you secure the neck and then immediately you can put the IV fluid. Yeah. Also different type of shock management, like hypovolemic shock, always you will find, even it's easy question, always it comes in the main exam. Hypovolemic shock patient, road traffic accident, lost blood, hypovolemic shock, give IV fluid initially. Very important. Then other type of shock, also IV fluid, except cardiogenic shock. Cardiogenic shock, we don't give any IV fluid. For channel opening, that's okay. But if you give extra fluid, it will be volume overload on the heart. So what do we give in the cardiogenic shock then? Or after a MI case, cardiogenic shock, what do we give? We give inotropes like adrenaline, dobutamine, these things. Okay. And septic shock, what, often you will be asked, what is the appropriate treatment in septic shock? Appropriate treatment. So appropriate treatment is a high dose of IV antibiotic. That is most appropriate treatment for septic shock. It seems like very easy ones, but it does come in the exam. It does come in the exam actually, in main exam. Yeah. And also there's another one, B string. Very recently I took that emergency related class, and the B string allergy. Yeah, that's high dose. I mean septic shock high dose. Yes. B string allergy. What do you want to recommend? Patient is having wheeze and respiratory problem. What is your management in B string? In B string, your management will be adrenaline. Okay, so I am adrenaline because when chest symptom present in B string, that means it is severe. Okay, and mild moderate cases you can give antihistamine or you can treat with prednisolone. That will be fine. But if it is severe, wheeze, chest compromise, definitely treat with adrenal increases actually. And we just also learn about the DC shock things actually little while ago. If patient is going to shock anytime you give. Now there's another question that comes. Pulseless case, they'll give you a scenario and at the end they're mentioning the patient is pulseless. Now how to deal with the pulseless? We give DC shock or we give CPR for that? What do you think, which one is more preferred? If a pulseless case, actually, if a pulseless case, you keep giving CPR. A lot of history, maybe I'm not sure you confirm, like what you have heard and what you have seen in your life, that how many times a CPR is given and patient is safe. I have documented, I have seen in like a 25 minutes, patient was totally down, I mean, falling to the water. CPR been given till reaching to the hospital for 25 minutes and went to hospital and the patient is wholly recovered. So what maximum time you have heard for CPR to save life? I mean, maybe it's a National Geography, maybe anything. So I've seen a documented one with a 25 minute. Quite good, not time. But I also read that, even with histories are there with 1 hour. Yeah. Imagine the people saved them. Yeah, for 1 hour giving CPR. But yeah, half an hour we heard actually. It's commonly, the same thing I was telling, that same singer KK, he was supposed to have CPR from the hotel to the hospital, right? People are just taking in a posh ambulance to come, and it's huge traffic area. Same like in Bangladesh, So because we suffered. I mean, I suffered because one of our relative, this thing has happened in past actually, just because of this huge traffic and wrong decision making. Everyone wants to go to the central hospital. Okay, maybe having a cardiac issue. Okay, I have to go to the biggest cardiac. Now that's the wrong decision. No, that's not the right decision actually. A medium level hospital can also at least give you the aspirin and basic thing, and they also have defibrillator actually. Okay, so they will also have ambulance, so they can also escort you later to the bigger hospital. That's one of the thing, we know, like of course death is confirmed and the thing, but living in big countries, at least there is chance that you may live a little bit more actually, because a lot of time we see the air ambulance comes too fast. The all you need a call, the air ambulance comes immediately. Yes, that's one of the thing. Okay, so this is one more. Severe dehydrated after IV saline. What's next after further 3 days along with this IV fluid? So question is actually about what's next after 3 further days. An IV fluid, which is like normal saline, is already given. Question is, do we need those potassiums or we don't need anything? Final answer is, this is a bit tricky actually. When you yeah, only test. Yeah, this is the best answer. Only test can tell that. Yeah, so this question either has some of the lab missing. After IV fluid, what is the status of the lab that is missing? Why unnecessarily, unless we have a abnormal lab or some ECG finding or anything, why we should give a potassium unnecessarily? Okay, so I think it's an incomplete question. So it's also important to rule out some of the incomplete type of question. Without lab, how can we do that? Or if we have to pick up one, I think it's no potassium needed, because when you give IV fluid, IV saline, normal saline, if you have any electrolyte issues, it is being corrected. I hope you will be agreed with that. Whenever you have some issues, you give this one, it will be corrected. Not with the normal saline. All right, so that's the thing. Okay, next question. Ethics question. Husband and wife, your patient with family has says that my life is may affect and has insomnia. Sorry about the words actually. A family friend is involved actually, and mainly telling maybe bit depressed as well, and having insomnia issue at the same time. Now that depends on the question, guys. Like say, uh, very incomplete. Yes, that's the thing. Uh, if you see, if this is a question related to depression, let me just clarify. How this question can be. If it is said that in the main exam, depression plus insomnia, then you go for the very popular mitra Zepine. Is it clear? Or patient is taking already a drug for depression and having insomnia, you can also go for mitrazapine. Now, if this question has no depression, I mean documented depression, you mean if no depression and only something related to insomnia and family issues, then you can go for consultation. Got my point? I just picked the answer, but I know that it's not correct. It's just for eyewash. But main, you understood the points actually. So depression, insomnia, matrazepine, already getting a depression drug and also having insomnia, change the drug to mitrazepine. I mean SSRI changed to mitrazepine. If this is actually case like this, a ethical point of view, and husband was having some issues, some family issues, and at the same time maybe some insomnia, then just a sedative and just some refer both for consult would be fine in that case. I hope you got my point. It's not a mitrazepine actually answer. It's just I put up one answer actually because this is a incomplete one. Okay, so you need to understand some of those incomplete ones while solving the recall. Some people waste a lot of time, especially on the recalls, because they couldn't come up with the answer. So sometimes if there is confusion, just learn about the differentials. So try to make a lot of differentials by yourself. So what can be more answer? Because that will save you in the exam actually, if you know how to exclude more options. Okay, so this kind of questions is better to read about SSRI, SNRI, TCA, MAO, and all these things. It's very, very important. SSRI has a lot of side effects, including sexual side effects, very often tested. And you should also know the classification and individual drug names. With the word sertraline, please check in the guideline. You might find 10, 12 questions with sertraline. Very, very important. Sertraline often comes in. Okay, so I think this is the last one question. Like, a man was taken from a prison after being aggressive or threatened to kill himself. He's convicted and currently serving time to kill his patients because he thinks they have replaced by double actually. I mean, he's thinking weird, no doubt. He's thinking very weird. Upon reviewing the history, you realize that has been diagnosed with schizophrenia. Of course, he's thinking aggressive, like filmy, plots. So was given dexamethasone and warden call and ask, what is your next step in the management? So this person is threatening to kill himself. So what is the best? Send the back to prison. Is it safe? Administer antipsychotic. Not safe. It's not safe for him and also for others. Release the man from the custody. No way. Send to prison hospital. Okay. And send to local psych unit. I hope you must be knowing that for the prison there is a separate prison hospital. Okay, so this was also somewhere I have seen this previous question, but it came again actually. So send him to prison hospital in this case. This is an ethical question. So send him to prison hospital. There are few words for few type of questions. Okay. Example, I can tell you more information, some of things like the example for in the psychiatry ethics, I'll tell you guys more. Example, those play gambles. and diagnosed with multi gambling and losing lot money. They borrow even money for playing gambles. So for them, there is a community group. Like, you have to go there and tell, I'm a gambler, has to do gambling and lost a lot of money. This thing happened. Same for alcoholics also is there. For alcoholic social groups are there. For gamblers, its name is Gambling Anonymous. Okay. Gambling Anonymous. It's a society or a group. Yeah. So same for like this prisoner, there's a prison hospital, you can say. So few specific question are for few specific answers. You need to keep it in mind. For example, a child abuse case, whom to call. Actually, specific answer has to be there. The child abuse case. So you have to call Child Protective Services. Child Protective Service. If the same with the child, if any sexual incidences happen, then whom to call? Now, is it Child Protective Service, social worker, or the police? Now it's police case. If it's a minor and sexual assault or anything, it's a police case. Yeah, you can say assault service, yeah. Okay, so a different question, you just need to be clear with different things actually. Time to time I'll tell you more. And yeah, so and I'll guide you guys some other day more with the psychotherapy. So I have compiled a nice file on the psychotherapy. I hope it will be helpful for you guys as well. So I thank you so much guys for attending the session. We'll catch up soon. I have to leave actually. I have to go and talk to my father as well. So do pray for him as well, that for his good health. And the thing, previously he never had any kind of health issues. He's currently 70. So maybe for the very first time, he's seeing something in his reports. So I hope so. He will be fine actually, and I hope so. But in your family, when you do the counseling, it doesn't. No matter, I counsel many people and the thing, and but when it comes to home, it's difficult. Yeah. So he also have this thing, the ventricular premature beats actually. So hopefully things will do pray for us. Yeah. Thank you so much, guys.